All right. Good morning, everyone. We're going to go ahead and get started. So the topic this morning is peer support, and it's part of our well-being initiatives in the Department of Surgery as well as on campus. And, to put it lightly, it's been a rough several months and a rough year for the Department of Surgery, right? With all the things going on in terms of government changes. We've had two very distinguished leaders in the Department of Surgery pass away within the last year, David Fullerton and Michael Wax, who are and were beloved. And, the stresses of our job actually keep increasing year over year over year. And it's really important to, just stop every once in a while and take a look at what the key issues are, what the resources we have in the department are on campus, what they are, and to look at what we're doing right. And, a lot of times what we're doing wrong in terms of helping the well-being of our faculty, staff, and trainees. So I really appreciate your attention. And I'm going to turn it over to our two leaders in the Department of Surgery, Zach Asher and Dr. Elizabeth David. And Zach, I believe you're going to come up and MC, right? Thank you.
Good morning, everyone. It is my distinct pleasure to introduce our esteemed speaker for today's Grand Rounds, Dr. Jenny Reese. Dr. Reese is a highly respected professor of pediatrics at the University of Colorado School of Medicine and the section head of pediatric hospital medicine at Children's Hospital, Colorado. Additionally, and related to today's Grand Rounds topic, she serves as the Assistant Dean of Faculty Wellbeing for the CU School of Medicine, Vice Chair for Faculty Wellbeing in the Department of Pediatrics, and is the Medical Director for Provider Wellbeing at Children's Hospital, Colorado. Dr. Reese's academic journey began with a Bachelor of Arts in Zoology from the University of Washington, followed by her Doctor of Medicine from the University of Washington School of Medicine. She completed her pediatrics internship and residency at the University of Colorado School of Medicine. Dr. Reese has been a dedicated hospitalist physician at Children's Hospital. Her leadership roles are extensive, including serving on the Colorado Department of Public Health and Environment Healthcare Worker Resilience and Retention Advisory Group. Nationally, she was the project lead for the Association of Pediatric Program Directors Longitudinal Education Assessment Research and Pediatric Resident Burnout Resilience Study Consortium. Dr. Reese's contributions to quality and safety have been recognized with numerous awards, including the Quality Pillar Award and the Medical Staff Award for Quality and Patient Safety. Her commitment to faculty and staff wellness is evident through her leadership in programs like the Flourish Curriculum, an evidence-based curriculum to promote individual well-being and resilience, practices taught to over 200 participants in a variety of audiences, locally and nationally, the REST team, and the Director of Children's Hospital Faculty and Provider Peer Support Network Program. Today, Dr. Reese will share her insights on peer support and well-being, drawing from her substantial experience and research in these areas. Her work has been pivotal in developing evidence-based interventions to enhance workplace well-being and resilience among healthcare professionals. Please join me in welcoming Dr. Reese.
Thank you, Zach. That was a nice introduction. I'm happy to be here, and I'm happy to see some friendly faces in the audience that I know, both from riding our bikes up mountains and also through work. And I'm going to spend some time talking to you today about sort of the logistics of a peer support program and how it works. But I will then sort of pose the question back to you, is this truly important? Is this something that we want to sort of enculturate here in the Department of Surgery? Because as much as the content is important, what you do with it will really be, I think, more significant. And I will get started here. I don't have any financial disclosures. And I do want to extend a huge thanks to Zach Asher, Dr. Elizabeth David, Dr. Duncan Wilcox, and many other colleagues who have been very supportive and collaborative in this effort. What we're going to cover today, the objectives are listed here. We're going to go over a little bit of what's in the literature about the impact of adverse events on surgeons. We'll talk about the importance and the benefits of peer support following adverse events, especially from the literature in surgery. And then we'll talk about a model of peer support here at CU School of Medicine and in the department. But before I go further, I'm going to invite Dr. Paul Maroney, who's graciously offered to come up and talk to you for a few minutes about some experiences that he's had in his work. And then after that, we'll continue.
Thanks, Jenny. And I'm going to share two stories. So one when I was a resident and another as a faculty member that I think are relevant here. And these are pretty sensitive and uncomfortable for me to talk about, but I'd like to share them with you anyway. So the first case as a resident, I was probably several months into my second year, and we did a lot of time in cardiothoracic surgery. And I don't know if you know about the Dunning-Kruger effect, but it's that thing where when you first start as an intern, you really don't feel like you know anything. And then after a while, you maybe get a little bit overconfident in your skills. And I was probably somewhere in that area. And I had watched an exchange between, it was a clinic visit with a patient that needed a semi-urgent valve replacement. And at that time, the residents did a lot of the consenting for the procedures. And so the faculty has the conversation with the resident. They say, Paul, can you wrap this up and do the consent with the patient? So, this is my job. Yeah, of course. And so the patient shows a lot of concern about, how she's going to do after this. And I just kept saying, oh, you're going to be fine. This was my experience in cardiothoracic surgeries. Like, patients generally did pretty well afterwards. Oh, be fine. Don't worry about it. It'll be okay. Well, during her surgery, and, I'm assuming the third position, just basically watching. And the surgery is pretty much over. They have the valve replaced, and she had had a prior heart surgery. So this was a redo. Well, at the very end of the surgery, she's off cardiopulmonary bypass. I can't remember if they'd already taken cannulas out and whatever, but the fellow kind of pushes a little bit on the ventricle, starts to bleed a little bit. Pushes a little bit harder on the ventricle, starts to bleed a little bit more. And then pretty soon they realize there's a tear in the ventricle and this patient's got no cannulas in for cardiopulmonary bypass. And they try to very hurriedly get cannulas put back in and get her put back on bypass. And the patient really never makes it off the table. And I felt terrible as a person to tell this patient she was going to be fine and then she died during the surgery. So fast forward now, and I'm faculty, and I have a patient with a large right-sided kidney tumor. And kidney tumors, if you don't know, they'll sometimes grow into the vena cava, and they'll grow in the vena cava sometimes up into the right atrium. And we're working with cardiothoracic surgery. This is another patient we're planning on putting on cardiopulmonary bypass. And one of the cannulas we put into the inferior vena cava below the tumor. So as we're working along, we're getting ready to put her on bypass so that we can excise the tumor. We put her on bypass. In the midst of all this, her chest is open, her abdomen's open, the azygos vein starts bleeding. It's kind of messy. We have to hurriedly get this tumor out. And meanwhile, in the background, the person that's running the perfusion is telling us pretty much the whole time that the patient has extremely low flow. And we realized only later that a retractor that I had placed was compressing the vena cava in a way that the flow that was supposed to be coming up through the vena cava from the lower extremities was not getting there. And when we woke the patient up, she didn't wake up. CAT scan showed a massive stroke, and the patient, we withdrew life support, or we withdrew support in the next couple of days. So these are just two things that I think about either willingly or unwillingly from time to time of patients that I haven't helped. And I know that's not what we're trying to do. So those are the stories I wanted to share.
So thank you, Paul. Before you go, just a couple of questions, if you don't mind. I'm going to use this. Can you hear me okay with this? So Paul, did you have any support after those events, either in residency or as a faculty?
No, I don't think there's any official mechanism or official support that I had. I feel like I healed and recovered from them, but I don't know if I was fully able to kind of process them at the time in a way that might have made me better faster.
And thank you. And what would have been most helpful for you, do you think, if it kind of looking back, either as a second-year resident or as a faculty member?
Yeah, I think probably having a couple of days to process it myself and think about it a little bit and see how it was affecting me. And I think if somebody comes up to me, 10 minutes after this or 15 minutes after, I'm not ready. But probably 2 or 3 days, I might have been ready to talk about it.
Yeah. Well, again, thank you. Clearly you're still having some emotional experiences reliving those events, and it takes a lot of courage and vulnerability to come up and do that. So I appreciate it. Thank you very much. So we all have these experiences, and it takes courage and vulnerability to talk about them. And as I think, Paul said, and I'll share a little bit more from what evidence we know is out there, there can be benefit to having a peer support conversation after adverse events. So peer support is defined here as non-mental health clinicians, which I'm assuming most of us in the room are, unless you've had some extra training before your surgical training. Non-mental health clinicians offering support to their colleagues after adverse events or other professionally stressful circumstances. So that's a pretty basic definition of what we're talking about. There are different types of peer support conversations, though. There are the formal, we've set up a program, we're arranging time to talk, you have a conversation that's planned. But then often there are these informal conversations, and I think these are the much more common type of peer support conversations that happen. They're on the fly, they kind of happen in passing, but ideally our peer support team and culture can start to influence what are the ways that these peer support conversations, whether they're formal or informal, can be as beneficial as possible. So when we're talking about adverse clinical events, it's defined really broadly. It's a healthcare-related event that causes distress to a patient, family, or their healthcare provider, which is us. And it can be a complication. It can be a adverse event or a medical error or a mistake. But it can be also any array of things that happen to us over the course of our days. Some of my most challenging adverse events have been really difficult interactions with patients' parents. So getting completely yelled at, emotionally eviscerated in front of the entire team on rounds by a parent that I had no idea was going to show up that way was one of the most stressful experiences I've had. Sometimes it's difficult interactions with our colleagues. So we want to make sure that we're defining adverse events very broadly. As Everybody knows we've had significant loss of 2 colleagues in the Department of Surgery recently. There's a lot of events going on in the world that are causing great distress. Several people said to me this morning, this is a very timely talk. So I just want to be clear that these conversations are not, only limited to certain kinds of events that we experience. And then just a quick definition of the term second victim. Second victims are healthcare providers involved in unanticipated adverse events and become victimized in the sense that they are traumatized. So again, we walk into the face of other people suffering every day. Sometimes those things that we see or experience can be very traumatic or triggering for us for any variety of reasons. So why is this important? I think everybody's familiar with the fact that to err is human from Don Berwick's IOM report. There's a lot of evidence that shows when we make medical error, that contributes to burnout. And there's additional evidence that shows that when we're burned out, we have a tendency to make more mistakes or quality of care goes down. So the purpose is to try to break this cycle as best we can. So a little bit of evidence from the literature as far as burnout and medical errors among surgeons. The study published by Tate Shanafelt in 2010 was a survey of nearly 8,000 members of the American College of Surgeons, and nearly 9% reported concern that they had made a major medical error in the last 3 months. And then those that reported that they had experienced a major medical error in the last 3 months also reported significant adverse relationship with mental quality of life, burnout, and symptoms of depression. So this article shows that when mistakes are made, they have a very significant negative impact on us as humans. And then in that same cohort, but in a different publication, it was also shown that the perception of having made a medical error in the prior 3 months was associated with a 3-fold increase in suicidal ideation. So this is really about all of our own personal health and well-being. After these events, any kind of reaction is very, very common, but not everybody obviously is going to react the same way. So it's important to start thinking about, number one, what are the things that you see in yourself after adverse events occur? And also being on the lookout for changes in behavior in your colleagues. Sometimes we're the last to notice that we're really suffering. After that adverse event I talked about where I just had a very difficult interaction with a parent, that was on a Tuesday. Sunday morning, I was in the parking garage walking into work and a colleague said, "Hey, Jenny, how are you doing?" And I burst into tears. And I kind of laughed to myself after a minute and thought, here I am, the peer support lady and the wellness lady, and probably I need to, seek some of my own resources and ask for help. So seeing these changes in others is also an opportunity to reach out. And then just making the case for peer support. I hope everybody feels like, yes, this is important. Yes, this could be valuable. But again, back to the literature. This is a study published in 2012. It was a 56-item survey to residents and attending physicians working in surgery, emergency medicine, and anesthesiology at a large tertiary academic hospital. 79% of these people that were surveyed reported that they had experienced an adverse patient event or traumatic personal event in the preceding year. And the outcomes that were looked at with the survey are their likelihood of seeking support, perceived barriers to support, awareness of resources, sources of support, and experience with stress. And the findings in this study showed that the reasons that people sought support or reached out to support are listed here in order of most common to less common. So legal situations and medical errors were the top 2 reasons people were seeking support, followed by adverse patient events, substance abuse, physical illness, mental illness, interpersonal conflict. And then the barriers to seeking support are many. So when you start to think about what are the experiences you've had? What kept you from reaching out? What kept you from having a conversation with a colleague that would have required some vulnerability? So time, of course, we're all busy. Difficulty with access or not knowing what the resources are. Concerns about confidentiality, negative impact on your career, medical legal consequences, shame, vulnerability, personal doubt, et cetera. And then when asked, this was a study just of physicians, when asked, what is your most desired form of support? the most common answer was another physician to talk to. So we want to talk to our peers and our colleagues. And that was over other programs like EAP or counseling services that were available. And then lastly, this was a survey of the American Pediatric Surgical Association, so pediatric surgeons. Again, 1,300 surgeons were surveyed with a 31% response rate. Over 80% of the pediatric surgeons in this study had personally experienced a medical error. 89%, almost all of them, wanted to or wished they had been contacted by someone for support. 45% said no one had reached out to them, and only 25% were satisfied with their institution's response. So the idea here is that we all experience adverse events. Most, but not all, wish they had some kind of support, and many are not getting the support that they would desire. So let's go to our local data. This is from the CU faculty and resident survey that went out last year. And one of the questions asked was, in the last year, did you experience one or more adverse clinical events that negatively impacted you? Surgery residents, 56% said yes. Among surgery physicians, 58% said yes. And then among those who said yes, they were asked, what experience did you have related to that event? Among the surgery residents, 51% said they received helpful peer support, which is great. 48% of the surgery physicians said they received helpful support, but 41% said, I did not receive peer support. So again, it's good that there's support happening. I also see this as there's probably an opportunity. And then these are some additional questions about peer support at work. I'm not going to go through all of them in detail, but basically if you look at the other questions asked, people listen empathetically when I talk about stress. They lift me up when I'm having a bad day, help me find solutions, pitch in when I need help. There was about a 52 to 75% favorable response from surgery physicians and surgery APPs, which again, I think glass half full or empty, it's great, but I also see that there's room for improvement. So the good news is we track these data over time, and hopefully in 2 years' time when we have our results and Zach and Dr. David are sharing them with you, we can maybe do some comparisons here. And some folks might be familiar with Jo Shapiro. She's an otolaryngologist out of Boston. She's one of the founders of peer support programs and has published a lot on the topic. She also talks about how peer support is important in our just culture. So how a shared organizational responsibility for clinician well-being and safety is part of peer support, and moving away from this culture of invulnerability, isolation, and shame. So we've covered, I hope, why peer support is important. We aim to reduce burnout, address the risk of suicide, improve quality and outcomes for our patients, and reduce medical errors. It is desired by most. It can help promote just culture, and it can help build a culture of support and improving morale. So what does a program look like? And here's where I want to pause for a moment and say, none of this is required. I asked Elizabeth and Zach if I could make a joke about, surgeons don't want to talk about their feelings, which is totally fine. This is not required. It's something that's offered to you and available to you should you want to participate. So the program that we've built here actually started back in 2015 through the School of Medicine Resilience Program and has been available on campus since that time, mostly focused at Children's Hospital because that's where I work and spend a lot of my time. But we're trying to expand this program across all of our departments on campus, and Department of Surgery is one of the early adopters. So we're referring to the AMA Steps Forward program. There's a lot of great resources on their website on the elements of an optimal peer support program. So this is sort of the timeline. First, making the case to leadership that peer support is essential, which I think because of the fact that I'm here and you have two well-being leaders that are driving this, I think we could check that box. Deciding which healthcare team members your program will serve. The general agreement here is that this is a program for all of Department of Surgery, faculty, trainees, and I would also extend to all support staff, people that work to support the clinicians in this department, I'm sure also experience adverse events and could benefit from peer support. Then we form a peer support team with strong communication skills, train peer supporters, and launch the program. And that is underway. I'll share a little bit more with you in a moment, as will Zach and Elizabeth. And then really launching the program. So that's the sort of start of that is what we're doing here today with Grand Rounds, and then this is going to continue over time. So as I've mentioned, Zach and Elizabeth are your team leaders as the Department of Surgery Wellbeing leaders. And then when you think about who are the people you want to talk to, who are the good, not good, but who are the kind of people that would provide the conversation that would be beneficial. And those people are described here. They're respected clinically, effective interpersonal skills. We aim for as much diversity as possible among our peer supporters, so that when you have someone you want to reach out to, there's someone who's very relatable that you would be comfortable talking to, considering a peer, and then looking at all of the right healthcare team members that can participate. So these are all the people already. We've offered 3 peer support training sessions to Department of Surgery. Would you raise your hand if you're one of the people who's undergone the training? Okay, look around the room so you can see who your peer supporters are. Hopefully you recognize these names. Thank you all for those who've showed up for our training. It's about an 1.5 to 2-hour training where we just go through the basics of peer support conversations, what an ideal conversation can look like, and then we talk a little bit more about the tenets of the program. So I'm going to give you just a little bit of what the training content entails. I'm not going to go through the whole training here, but if you are someone who hasn't participated in the training and you're interested in becoming a peer supporter, please reach out to Zach and Elizabeth and we can talk about, we offer a training about every 2 to 3 months and they're open to whoever wants to attend. Our first 3 were specific to Department of Surgery and we can certainly talk about offering more as needed or inviting people to join our regular trainings that we offer. So the tenets are pretty straightforward. We use this model, ask, listen, connect. And the ask is really just an invitation to talk. Do you want to talk? Is this a good time? How are you doing? Paul, courageously came up and told his story. And he also told us, I would have needed a couple of days before I was ready to talk. So really being respectful of the person and where they are. If you are in the middle of a shift or have to get through your day, it might not be a good time. But knowing that somebody is there and offering an opportunity to find a time to talk is part of that. And then the second part is listen. And this is the part where during our training, we sort of sometimes uncomfortably force people to listen. We get into small groups and ask people to share their stories. And the people listening are asked not to interrupt, not to interject, not to sort of redirect, really to give the person telling their story a chance to say whatever they want to say. Take as much time as they want. I said, Paul, will you come and tell your story? I didn't give him any directive. I didn't interrupt him. I just he told what he was willing to share. And that's what we're setting up for in these peer support conversations. But then we also practice reflective listening as well. So going a little deeper into what I heard you say that was really emotional, or you felt scared, or you felt ashamed, or really sad. And then connect. I'm here for you. Can I reach back out in a few days? If you want to talk again, here's how to find me. And then just a little more detail, some of the tenets, the elements of ideal peer support conversations from the Step Forward modules. Normalize. So first of all, typically what we do in our training is after people have a chance to share their stories, then we say what kind of things are helpful for you in a peer support conversation and or what kind of things don't you want to hear. Most of the time people say, I want to be told I'm not alone. I'm not the first person this has ever happened to. I want to be validated. I want to be listened to. Some reflective listening prompts. Often we can bring in a little bit of conversation around coping skills, and that's something that we cover in our training. Sometimes a reframe can be helpful toward the end of the conversation. No one ever says, I want to be given unsolicited advice. No one ever is told, I want to have my medical decision-making dissected and analyzed and criticized. These are really conversations about your emotional response to the case, and the medical event reviews happen in a different forum. So the way this is going to work, and again, Zach's going to share a little bit more about the process for Department of Surgery, but what we're trying to set up with this program is that when an adverse event occurs, a referral can happen, either self-referral or referral of a colleague. The peer support champions are contacted and or notified. And then a match takes place where somebody says, okay, I'm your peer supporter, I'm here to talk, and then a conversation ensues. And part of the challenge of this program, and part of the reason that socializing it is so important, is we don't ever want somebody to feel blindsided by an offer of peer support. So we'd really like for everyone in the department to at least know what this program is. Again, it's never required. It's not punitive. Conversations are confidential. We'll talk a little more about that. But if somebody, reaches out to you and says, hey, I understand there was an adverse event, I'm your peer supporter, all that means is they were notified that an adverse event happened. There's no details shared. There's no case specifics given, just, hey, this person might benefit from a conversation. And then it's up to you to share as much or as little as you want about the event. Some specifics about what to avoid in peer support conversations, avoiding, again, as I said, analyzing the medical decision-making. I'll talk a little bit more in a minute here about risk management and legal and how they're involved in this program. Avoiding giving unsolicited advice, really maintaining confidentiality, and that, as we've already covered, avoiding making someone talk about an event if they don't want to. So we've reviewed this program and all of our training content with risk management and legal affairs at Children's Hospital and through CU Medicine. They are supportive of the program. They know it exists. They reviewed our curriculum and essentially approved it. And they even wrote one of the lawyers at Children's even wrote a slide for us to use in our training. And the slide is really kind of titled, the conversations are essential, but here's how we can minimize risk and exposure to you as peer supporters if litigation does occur. And then we sort of go into what that looks like, basically saying we don't keep notes, we don't dive into the details of the medical case, and we maintain confidentiality. So also, I think it's important that everyone knows that if you're ever named in a claim, just in your role as CU resident, fellow, faculty, there's automatically a peer support referral through the risk management affairs team. And those peer supporters, if you're named in a claim, those peer supporters are folks who have gone through the litigation process themselves, and they have also undergone peer support training. So I'm really glad for the fact that our team sees value in this, and they're not saying, don't talk to anybody if you've had an adverse event because we're afraid, we're going to get in trouble. So I think this is important for everybody to know. In the 10 years of this program on campus, I've never heard of a peer supporter being subpoenaed or there being any problem with a lawsuit around peer support, but that's just my anecdotal evidence. So the next steps in this program, as I kind of already alluded to, we've already done 3 training and trained a great number of peer supporters, but as I said, there's additional training opportunities if additional people are interested. Really socializing the program, so grant rounds, hopefully working with our communications team. I see Kristen here today, who works with the Office of Faculty Experience, to help kind of just let everybody know what this program is and that it exists. And then setting up a little more information on like your website with QR code that you can access, which we'll share here in a second. And then the other, I think the most important part, I've already said this kind of once, but is really kind of, if indeed this is the intention, to enculturate this into the fabric of how you work. I was gonna say how you operate, but that's kind of a dumb pun. Just kind of how you work in the midst of this department. If and when adverse events happen, there's a sort of natural chain of communication that normalizes offering a conversation of support, if this is something that you want to pursue. So that if you are reached out to, you're not blindsided. Oh, that's what that is. Yeah, I want to talk, or no, I'm good. Thanks for asking. So again, socializing the program within your department, identifying peer support champions. We have 2 peer support champions, probably could use a few more to help with the sort of reaching out and matching and things like that. Materials available to include with the peer support offer so people know what the program is if they've forgotten. And then just avoiding anybody being surprised or feeling more stressed by the fact that somebody has reached out to them. So I'm going to hand the mic over here to Elizabeth and Zach in just a moment, but if we have time after they talk and have time for discussion, I'd be curious to know, is this something that people want to incorporate into this department? A reminder that this is non-punitive and confidential. What does role modeling from leaders look like? What does it take to sort of make this a little more acceptable or standard practice within the department? And any other thoughts that you might have? Zach and Elizabeth, do you want to come up? And while they're coming up, I'd like to make sure everybody is aware of additional resources for support. I don't think I should give a well-being talk without acknowledging. We have faculty and staff mental health clinic. There's a 24-hour hotline. There are now resources. It used to be COVID recovery. Now it's sort of transitioning into how do we survive and everything that's coming our way next. So I'll, again, share this information, but if you want to grab a screenshot of that, feel free. Okay, do you want to use the?
Is that working? Or if you want to keep yours, you can. Okay,
Keep them.
we can, yeah. Show me advance.
These are my references. Oh, I'm sorry, one more quick thing. Before I hand the mic over, I wanted to give Zach a shout out. He actually had reached out a couple years ago to bring the peer support training to staff and faculty in the surgical trauma ICU. We offered peer support training to not only physicians, but also nurses and respiratory therapists and other ancillary staff. And then he had his abstract accepted for a podium presentation at the Society of Critical Care Medicine. Congrats.
Yes. All right. Good morning, everyone. Okay. So I'd first like to thank Dr. Reese for her tremendous leadership in this space. And hopefully the importance of this is really coming through this morning. So the first thing we wanted to go through is really how are we going to access peer support? And here are the ways. You can contact me, you can contact Zach, or you can use this QR code, which we are going to circulate in the OR and in the team rooms. And as Dr. Reese mentioned, anyone can refer. You can refer yourself, you can refer a colleague. If you have a case where something unexpected occurs, you can walk out of the room, access this QR code, and it prompts a form. And the form is going to ask you, who do you want to receive peer support from? Physician in an APP. It'll ask if you're referring someone else or yourself. What else does it ask? And how we contact you. And then one of us will reach out and we will get you connected. Say something else. Okay, and just a second reminder that if you are contacted because you have been referred for peer support, it is not punitive. It doesn't mean that there is something wrong with you. It means that someone cares enough about you to have taken the 30 seconds or a minute to suggest that it might help you. So please don't think that there is anything wrong if you are contacted by one of us.
And I think having somebody in mind before you're in the throes of an adverse event is pretty important. Having, some people call them failure friends, some people call them burnout buddies, but having somebody before the event happens in your mind, who would you want to reach out to? Who's a respected peer, whether they've had peer support training or not? We encourage those who have undergone the training, but having that person in mind is really important before you're in the middle of an event.
Yeah. So we have the names up again. These are all of the people who have gone through training so far. We are trying really hard to have at least one physician and one APP from each division. And I'm pretty sure we're close to achieving that. There are 37 names on this slide. So representing more than 10% of the department has been trained. I think that's really great. We welcome other interested people to do the training. It is kind of fun. Okay, so hopefully we're nailing this one home. You know, there is nothing that is meant to be punitive about this at all. And actually, Jenny, this is one of my questions for you is peer support is confidential. And a lot of what is discussed are feelings of shame, feelings of guilt. So how do we balance the confidentiality with sometimes talking about those things to many people helps with the feelings of shame? How do we balance those?
Yeah, that's a great question. I think role modeling like you're doing here. So if you're providing peer support to me and I say, I feel really ashamed, we're going to have a confidential conversation. You're not going to go tell everybody in the room, Jenny feels really shameful today. But I might choose to tell my story to a few people and kind of normalize, hey, this happened. Here's what my reaction was. Here's what my response was. If you're an attending working with a group of residents, you might take a moment and say, that was a difficult case. I feel a little bit ashamed, or I feel, concerned about that conversation I had with the family. How is everybody else doing? So I think you can kind of role model the vulnerability, but the peer support conversations themselves are certainly not to be shared outside the duo. Does that answer your question? Mm-hmm.
And again, these conversations and interactions, they're not recorded. We're not tracking at the accession of peer support, and it is certainly not mandatory. So we have one last piece, but I want to open it up to questions from the audience for Dr. Reese or for Zach and I. Dr. Schulich.
Yeah, so first of all, thank you for the tremendous amount of work you put into this, Dr. Reese, over the last decade or so. And Dr. David and Zach, I know you put a ton of work into this, and we're just beginning to get traction now that we have some kind of meat on the bones. I want to thank all the department leaders for the many conversations, division chiefs and others, for the many conversations they've had in this space over the past decades. And we've kind of done it randomly and informally. And the problem with that is you miss people. And you don't always say the right things. And you don't follow best practices is the problem. But I certainly have had lots of conversations. I know every division chief has, and it takes a lot of time and effort, and it's the right thing to do. But we've probably, as the survey shows, have left 40-something% of the people behind just because maybe we were busy that day, or the mechanisms didn't get triggered. So I think formalizing this and training people to do it at the best of their abilities is really important. And I have had many conversations with other surgeons, and I'd be interested in your thoughts about this, but I can see people get very relieved when I say, this happened to me. And then it's not, they don't feel like they're an outlier anymore, or they're not special in terms of making a bad mistake. And, almost every bad event, if I'm talking to somebody, I've done it, and it's just part of being a surgeon. It's part of being a physician. And I think just, not overdoing it, but just saying, this happened to me, and this is, and this is eventually what happened, and it's bad, but it works out, and here are some of the things, and just opening up that conversation is very important. I think some people are surprised, that most other people have gone through all these events, and if you practice in surgery for 30 years, you've made every mistake in the book.
Thank you. I think next turn.
Well, we're shifting the mic. I would totally agree with Dr. Schulich. I know from my personal experience, when I've talked with colleagues and friends about something that was really bothering me, it is tremendously helpful to hear that they've gone through the same thing or a similar thing. And I think that's what's so important about some of the shame that magnifies the adverse aspect of some of these events, is just talking about them and realizing you're not the only person to experience it.
Yeah, I'm one of the person that actually talked several times about that. No, saying that, thank you really very much for, this is extremely important. I wanna give you a perspective of someone that lived in 3 different countries, and I wanna give you a perspective of what I think. So I think the plan you have here for formal support is amazing and extremely needed. However, I believe there is one area, in my opinion, we should also don't forget, the cultural change or shift. My experience in this country, people are very reluctant to talk and are very reluctant to give you time to talk, right? To me, if one of my faculty called me 9 o'clock in the evening as a problem, I talk even until midnight. I don't want to say that should be the practice, but what I'm saying is, if you get a problem, waiting 1 week to have someone talking with you means I don't care about you. Should be now, because the maximum anxiety is now. So I think the 2 things should be done together. It's not that one exclude the other, but even diffuse the culture that your door is open for your colleagues, your peer, feeling friendly in this moment, seeing a face that you trust, I think is very important. And feeling that speaking and talking about problems with other people is a value, is not something to be ashamed. I think this is something also I will work on, because to me, that's the real peer support. Someone I trust, someone I feel close to me, and let me feel listened, not just by appointment, but because in this moment I need. Thank you.
Thank you very much. I appreciate that. And I would love to echo what Zach said. I call it a go-to. When you, as a leader, reach out to a colleague, when you've had a difficult event, then they see you being vulnerable. They see you modeling this, and they think, oh, wow, my leader is doing this. I can do this too. So I think that's a really important point. Thanks.
Thank you very much. Great presentation and discussion. 2 things really quickly. One is when we were doing a lot of the work around sort of psychological trauma during the pandemic 4 or 5 years ago, one of the things that I thought was most illuminating that I heard from someone who does a lot of this was when you look at a traumatic event and you're assessing potentially what the impact is, this person said, I don't want to know the details of that event. I want to know the last thing before this that someone went through, because the effect is cumulative, and someone that suffered whatever trauma, and there are a lot of them to go around these days, will be much less prepared, potentially much more vulnerable to the trauma they experienced then. And the other is, I second what Dr. Schulich said in terms of supporting our faculty and our peers. And I think one of the things that surgical leaders owe it to their faculty to do is identify situations that someone may be getting into that are potentially going to be problematic if they don't go well. When I was a resident, one of the staff cardiothoracic surgeons was doing an open heart procedure on his dad, and his dad actually never made it off the table. Now that's an extreme example that could not happen today, I don't think. But my point is, if we see someone that's working way into the night doing sort of risky cases when maybe the staff support isn't there, I think it's important that we antecedently say, you need to think about this a little bit and think about why you're doing this, because I think some of these things are probably preventable to some extent if we're just sensitive to the signals that are being given.
Yeah, thank you. Good point. And I know it appears there are a lot of trainees in the room. I'm wondering, I'm assuming it's going to be a really difficult conversation for a resident to reach out to a division chief and say, hey, I made a mistake. I feel really bad about that. How can we support our trainees early on in their careers to sort of make this a part of, this is how we do what we do here, without sort of worrying about that? This is also the person who's evaluating me, and I'm concerned about, how this is going to reflect on me. I don't know if any trainee, yeah, back in the back here.
Well, it's not necessarily a formal process, but, the trainees have all of our cells in leadership. They text all the time, talk all the time. And so it's not uncommon for them to reach out to me if something happened that they were not happy about. I mean, who knows what the total N of the times that they have things happen and the number of times they reach out. And, it's not just me. They reach out to the APDs as well. Yeah. So it's not a formal process like you're describing there. It's more of a, sort of talking to a older sibling or something like that. So we do have that.
Great. Sounds like it's part of the culture to reach out and have support.
I think it's cognizant to remember as the attending surgeons that it may not be traumatic to you, but it may be traumatic or stressful to the APPs on the team or the residents or fellows on the team that don't have the experience or the perspective that some of the more tenured faculty have as well. So referring them is also non-punitive and mandatory, but something to consider while you're in difficult cases.
I'm a fellow here at Colorado. When I was a resident, my second year, I made a big mistake and I ended up calling my upper level and then ended up calling my chair, which might have been a little excessive, but was so like distraught about it. And his response was what has kept me kind of being able to go to people above me. Because he, instead of kind of being punitive, like you've all said, he was like, I've been there, I've done the same exact thing. And in fact, I like really applaud you for calling me and like, let's talk this through. And so getting that like almost positive feedback in a negative or in a negative situation has then, one, it improved my relationship with the chair where I felt like I could at that point call him with anything, which I'm sure he loved, but it also just again kind of reinforced that when these situations come up, I feel like the right thing for me to do is to reach out to these people and I will get hopefully a positive response.
That's great. That's a great story. Thank you. Any other questions? Yeah, Dr. Sheila?
If you're concerned enough to refer somebody, I would also think, maybe that's the right time to just say something to that person. This was a horrible event. I feel bad. I know you feel bad. I'm available to talk. I'm putting in a request to our peer support team. I think I would like to hear that. And I know it's not possible every time, and some people may be embarrassed to do that, but just to let somebody know, look, I care enough that I'm going to get help for you and for me and for us.
Yeah, I echo that. And I always tell my trainees and my patients that if you think about calling, just call. Don't go down this rabbit hole of, do I really need to call? If you're thinking about, oh, would this be helpful for someone, just call us, email us, or access the QR code. We're happy to hear from people.
And this should be a tab on our CU survey.
Yep.
Robert?
Yeah, thanks for the presentation, all three of you. I've struggled with the quality improvement part of this. So Dr. Reese, I'd love to hear your thoughts on how quality improvement efforts impact on this entire field, because I think of an adverse event in a case and then it goes to the hospital's quality improvement committee and then it goes to the infection prevention committee and then it goes to the mortality committee and then it ends up at the risk management committee, and the individual faculty member might have to attend 6 different quality improvement committees to talk about the exact same case. And as a division chief, I have struggled with, I cannot talk about this case at another conference, and I can't allow the faculty member to have to attend another meeting about this particular case. And how can we do better with that particular thing?
Yeah, absolutely. Excellent point. I think there's a lot we could say about that. Number one, as leaders, how can we maybe rethink how we do this inquisition when adverse events happen? I know we don't have full control over what happens at the various hospital levels, making sure that faculty is supported every step of the way through those presentations, through those meetings. At Children's, I don't know about here, but in our hospitalist case conference and our Children's Hospital case conference, we always start with an acknowledgement about the importance of just culture and peer support and non-blame, non-punitive environment as best we can. So I think that it's going to have to come from many angles, and having voices of champions like you to say, wait a minute, what about the physician or clinician here who's becoming victimized, as to use the term second victim, and call it out and do what we can to sort of shift the culture when there's an opportunity. If you see a inquisition happening during a case conference, do you speak up on behalf of that faculty member and say, this might be not in this person's best interest the way this conversation is going? I don't go to M&M, surgery M&Ms since I've been a medical student, but when I used to go, they were not always the most hospitable environment. So yeah, I think it's really thinking about all of those elements, Robert, and your position of power that maybe you can help make some changes to the process.
And then I want to take the opportunity to thank Dr. Schulich. In 2012, the Aurora Theater shooting happened. And just like Paul, I think all of us, our brains turn on to, we have business to take care of, and we don't think about these issues until a delayed fashion, just like Paul said that it was 3 days. I remember the next day, I was, organizing the care of the patients, and Dr. Schulich called me and said, how's it going? And I said, oh, we're doing this and we're doing that. We're doing, my brain was in the take care of the patient mode. And he said, that's not what I meant. Are we taking care of the residents? Are we taking care of your faculty? How are you doing? And he took the time that day to, I think, contact the chair of psychiatry and to try to garner resources, which didn't exist in 2012 that way. And it was really an event in my own professional career that made me start to think more about this topic.
Mm-hmm.
Because up to that point, I don't think I ever really had.
Thank you, Robert. Paul, and I agree. I share your sentiments about appreciation for Dr. Schulich. When I went into his office, I don't know if you remember, it was probably 13 or 14 and said, oh, I want to do wellness. You're very respectful and supportive of the concept.
Yeah, and I want to just point out what Zach said. In my house, I know where my fire extinguishers are and stuff like that. And I think before you end up in this situation, know who that person is you're going to talk to. So think about that today, even if you walk out of here with the to-do list, is like, who's that person I would go talk to? Maybe if you want to mention to them, hey, look, I might lean on you someday for peer support. And if you're that person, take that as an incredible honor.
Yeah.
And consider if you have maybe attending the class, it's short and easy. They usually do it at pretty good times. Jenny has a cheat sheet that I keep in my notes in my phone. So if somebody does come to me for peer support, I know I can go to that really quickly. God, I didn't take the class a year ago and I don't remember. I can go to that sheet and say, okay, well, here are the things that I need to hit. So take that as an honor. Think about today who that person is you would want to lean on.
All right. Thank you guys very much for listening, for chatting this morning. I think it's great. The last thing, and this is the reason I came back to this slide, we are starting to build the 2026 survey for the School of Medicine. So if there are topics that you want to have included in the survey, please feel free to email us. The best way, to get what we want out of it is to really make sure that the questions we think are important are what are asked. So please reach out to us if you have ideas, things that you think should be included in the survey.
And I'm available anytime for questions or any more information about peer support or other things well-being related.
Thank you. Thank you so much, Jenny. We have a little gift for you.